for inviting me to give my talk regarding the National Cancer Control Program. But the title given to me was the role of government in cancer care in Korea, because I was not working for the government, because I do not have any good idea of what should be the role of government, but I give my impression, what I think, what has been done in Korea. And I'm going to talk about the cancer burden in Korea and the healthcare system as an overview, and introduce the National Cancer Control Program in Korea and their activities. And Korea ranked number 1 or very high in cancer burden. Korea has the cancer as the leading cause of cancer death in Korea ever since the data was available since 1983. And although the population is almost 0.67% compared to global population, the incidence was 1.53%, mortality is 0.9%, and prevalence is 1.7%, very high because of the aging populations. And this is most recent cancer site for men. For men, the stomach is number 1, lung cancer, colorectal cancer, liver cancer, and prostate cancer. For the woman, surprisingly, thyroid cancer number 1, breast cancer number 2, third was colorectal, outnumbering the stomach cancer, and 5th is the lung cancer. And this is summary of the population attributable fraction of causes of cancer in Korea. And in 2009, the smoking and infection was the major contributing factor for incidence as well as mortality. Actually, the infection is a little more than the smoking in Korea. The healthcare system in Korea is the universal coverage single-payer system since 2000. It was a value-based fee-for-service system. It has merit and disadvantages, and it's a core payment ceiling. And there is a special advantage of being a cancer patient with a lower co-payment and more benefit from the government insurance. And the Reducing the Cancer Burden National Cancer Control Program based on WHO guidelines in the primary prevention, second prevention, as well as better treatment, and precision medicine and the quality of life, end-of-life care, all covered by the insurance. And I like to introduce the one idea of lifestyle modification is very important, but also education and the legal action is very important for government role. And we have this March 21st is the Cancer Prevention Day. Annually, we have the celebration for local government as well as the central government. And this is my summary of the role of government. Planning and government is very important, and the legislation support is very important from the government's point of view, and the building the infrastructure and the capacity building for the cancer control, and the program development, and most importantly, funding for the program operation as well as research for cancer. And this is based on the WHO guideline for effective programs. And this slide is the second 10-year plan for cancer control based on the life cycle of cancer from healthy individual and the early detection and the treatment, and then palliative care and the quality of life assurance based on the cancer registry, education advocating, and also the expanding the capacities. And this is supported by the research, basic research, translational research, clinical, and policy research. This is a summary of national actions for cancer control in Korea. The idea establishing cancer control was first started in 1989, and 3 years later, construction of National Cancer Center Hospital started. And during the process in 1996, first 10-year plan was started for 10-year plan, and the cancer screening program was started in 1999. And then we had the National Cancer Sector Act in 2000, and the Cancer Control Act in 2003. And in 2010, Cancer Control Act was totally revised to incorporate National Cancer Center Act. So we belong to the Cancer Control Act. The main content of cancer control, you see this one in summary. There's a central and regional government must establish a plan for cancer control every 5 years. And they establish a National Cancer Control Committee in the central government and designate March 21st as the Cancer Prevention Day. And all the program is supported and is implemented included in the Cancer Control Act. And as I mentioned, the National Cancer Center Act was emerged into this one, and the legal action is very important. When with the cancer registry, we had some problem with the personal information protection law. So we revised the Cancer Control Act to follow the statistic law, but we have the special the division to be exempt from the personal information protection law 3 years ago. And this basically summarized the 10-year plan was constructing the infrastructure for the cancer control, building capacity of cancer control, and also set up a program for cancer control. And second 10-year plan, operating the cancer control program more effectively and efficiently, we set up the goal to decrease the mortality by 90.4% and 5-year survival rate up to 54%, but based on our preliminary idea, but that goal was revised as we have the more updated data. This is the beginning of the hardware for National Cancer Center. We started the building in 1992, December, usually December 30th, coldest day of the year. And 3 years later, the hospital was under construction. It took almost 7 years to open it. And then most recent the shape is here. This is the hospital building. This is the research building. This is the cancer prevention building. And we have the 4 major functions as research and patient care, as well as education and training with the postgraduate school, and then support for the National Cancer Control Programs. National Cancer Center function as a think tank and also execution do tank for formulating and implementing National Cancer Control Programs. Also, we organized the infrastructure by appointing the 12 regional cancer centers, closely collaborating with our cancer control programs. And doing this, most important part of it is population-based cancer registry. It provides all the ideas, all the data, and the re-evaluate the situation. So there's a Korea Central Cancer Registry. It was started in 1980s as a hospital-based cancer registry. It was transferred to National Cancer Center in year 2000. We had this program to oversighting all the activities. The coverage rate more than 98%. These are cancer statistics. We include the incidence rate and the survival as well as the prevalence, which started reported since 2009, and the survival by SEER stage since 2013. It was provided in all the IACS, the cancer incidence in 5 continents, volume 9 and volume 10. And also, it was usually reported the annual report form, which is very difficult to find out. But currently, it was published cancer statistics and the prediction of new cancer incidence every year in the journal. So it is easily acceptable. And this information is available in public. This is the revised goal for the second 10-year the cancer plan. It was originally reducing the mortality rate for 100,000 population from 112 down to 94, but it changed to 88. And 5-year survival rate increased from 54% to 67.8%. It is overachieved by now. This summarizes the outcome of our cancer control program in Korea. We have the mortality data since 1983 and the incidence data from 1999. But here, this is most recent data. The incidences of both men and women combined, 259. and both the mortality is 82. And it's important to notice it started decreasing from 2012, and the mortality started decreasing in 2003. This is the time the control plan is executed from 1996. This trend in cancer mortality rate is not only the stomach cancer, which is naturally going down, but also the liver cancer. And very important thing is the lung cancer, the mortality increased, but started decrease from 2000 around that time. And there is an increase in this is the colorectal cancer, but it is still coming down. And very important thing is, this is the bottom line, is the thyroid cancer mortality, almost non-seen. In women, the mortality for stomach cancer decreased, and also there is an increase in the lung cancer, become #1 mortality in Korea for women. And mortality for the thyroid cancer is down almost 0. 5-year survival rate, it is increased up to 70%, 70.7% in the most recent years. And before the National Cancer Control Program started, between 93 and 95, the 5-year survival rate is 41.2%. For the male, it increased up to 63%. For female, it's up to 79% 5-year survival rate. But if you look at this one, for major cancer types, for both men and women combined, there is a 100% 5-year survival, actually 100.3% for thyroid cancer. In other words, the thyroid cancer detected, they come to the medical the network, they have the better survival, relative survival rate. But overall, the stomach cancer, colorectal cancer, up to 76, 75% range, and breast cancer up to 92%, and prostate cancer 94%, and kidney cancer 82%. Most worst prognosis is the pancreatic cancer. And even in lung cancer, liver cancer, there is a significant increase over time. This is the OECD health statistic data in 1913. That time Korea ranked #1 for colorectal, the cervical cancer, as well as the colorectal cancer. And breast cancer rate is way down, was 85%. If you include the most recent data, it should go up very high. This is comparison, most recent 5-year survival, relative survival rate in Korea between year 2011 and 15. It's better than the USA, Canada, or Japan, even though there is some discrepancy in terms of the year reported. But even for the breast cancer, it's 92%. And the only difference was the prostate cancer. Prostate cancer is low, but now is catching up, 94%. There give you some activities in national cancer control activities in Korea. These are the primary prevention activities, cancer information services provided all the web page and the social media and the cancer, the call centers, education material, and all the booklet, leaflet guidelines provided. This is the 10 code for cancer prevention in Korea, which was updated 3 years ago. And this is including all the smoking, food, activity, alcohol, etc., and also the vaccination, and also the on-the-go routine checkup following the cancer screening programs. It was revised to include the HPV as a vaccination program and to avoid alcohol consumption. Previously, it was said to avoid alcohol consumption 1 or 2, below 2 drinks, but nowadays, to avoid alcoholic consumptions. This is a practical guideline for cancer prevention for public education purposes based on the practical guideline for 10 major risk factors: smoke, the drinking, and the cancer, the screening, all the activities and diet, smoking cessation, and weight control. and also practical guideline prevention 11 major cancer types. This is public campaign activities usually on the March 21st, and mass media campaigning and the offline campaign, and providing all the campaign materials. And also regarding the smoking, we implemented the FCTC guidelines, adoption of the various tobacco control policies program since the rectification of the FCTC about 13 years ago. And adult smoking rate decreased 39% above age 18 years old or more, and 4% reduction in male in 2015 after tax increase, and also did the labeling package insertion of here, and the public media campaign on tobacco harm and offering cessations on public media. And although the smoking rate is down, this is the smoking population age 15 or older, the OECD, the health statistic. There is a big difference in men and women. So it should be focused more to reduce the smoking rate in men. The another activity is primary prevention is the HPV vaccination, which started in 1985 as a temporary basis, and in 1995 it included is a nationwide childhood immunization program. There is a shift in hepatitis B surface antigen positivity rate by age group, and we hope we see the decrease in the liver cancer, hepatoma mortality over time. And the second prevention is the screening and early detection. This is the guideline for 5 different cancer types: stomach, liver, colorectal, breast, and cervical cancer. And most recently, it is devised to repeat the screening for liver cancer by liver ultrasound, as well as alpha-fetoprotein for high-risk groups such as hepatitis B carrier, as well as hepatitis C positive cases. And cervical cancer screening by pap smear, the age was reduced down to 20 from 30. And the milestones of the National Cancer Screening Program, which is started in 1999, we covered the stomach, breast, cervical cancer for Medicaid recipient, low-income groups, and then it increased, and the coverage increased. And 2003, liver cancer added. 2004, colorectal cancer added as a national cancer screening program. And then we devised the guidelines after extensive review of the performance of the screening. And we shortened the liver cancer screening interval every 6 months, and lowered the starting age of pap smear down to 20 years. And during that time, we decided to add low-dose CT scan for lung cancer screening for high-risk groups, but not to recommend the thyroid cancer screening for general public because of the overdiagnosis issue. This is the low-dose CT screening for the feasibility study. We have the preliminary pilot studies. We screened more than 5,700 cases, and they found 29 lung cancer. The frequency of the stage 1-2 resectable disease of 56% compared to 21% for historical control. So screening can detect early stage lung cancer. And it's covered by the National Health Insurance System, depending on their premium. The premium lower half is free of charge, and the upper half is 10% deductions. And this is the organizing screening. Cancer participant rate increased over time up to 82%. And this is the screening for the lung cancer, the National Cancer Screening Program guidelines. Overall, about 2/3 of them follow the screening. The reason for not undergoing the screening process, initially they believe they were healthy, they don't need the screening, but their belief system is down. And we worry about the economic reason, the financial burden, but it was not a real issue in our Korean society. And this is the challenge of the National Cancer Program. The increasing screening rate is increased. Evaluating the improving the quality of the screening, we have the education program. And evaluate effectiveness, we revise the programs. And modifying the pitfalls of the diagnosis issue. And assessing the cost effectiveness, we do not have the data yet. But it's I have a little more slide to go over. This endoscopy is the one, the upper endoscopy. Initially, they prefer the upper GI X-rays, but now more than 70% of the participants prefer endoscopy. And it have evidence that upper endoscopy could reduce the cancer, stomach cancer mortality compared to never screened individual. Anybody who had ever screened, they have the 79%, 21% reduction. But the evaluating with the endoscopy, the overall, the odds ratio is 0.53, 47% reduction, but the upper GI CDH has no significant impact on this. But as the number of endoscopic screening, there is an increase, the odds ratio further down, decreased. So the more screening with the endoscopy, the less chance to die from stomach cancer. And also the colon cancer is the fecal to occult blood test. The preference, if they're positive, they have a choice either double contrast very minimum or colonoscopy. Now it's almost 88% prefer the colonoscopy as the facility and the safety of this process is well recognized by the Korean people. And this is the colorectal cancer that I think detection was increased and the incidence rate is coming down starting from 2011. Every year, percent decrease changes 7.6%. In men, almost everything coming down, and thyroid cancer coming down over here. And it's a female, the thyroid cancer incidence skyrocketed up to here, every year about 23%. But after some public campaign or recognition of this false diagnosis or overdiagnosis issue is coming down. And the colorectal cancer became increasing and coming down, and breast cancer keep rising, and I'll explain a little bit more. This is the IAC data. The most common cancer differ by country and by region and by gender. The female, male is population here, either prostate cancer or lung cancer. But for women, either breast cancer or the cervical cancer is the most common cause of death. But only one country, Korea, is number one in terms of thyroid cancer. Korea is the only country in the world that thyroid cancer is the most common cancer among women. Why? Overdiagnosis. This is the pitfalls of cancer screening. You are overdiagnosed. In many cases, they underwent unnecessary thyroidectomy. This is the data in Global Can 12, and most data. Still, Korea is the number one. But one striking thing is lung cancer is the number one in North Korea. This is the only country. I don't know the reason why. This is the impact of overdiagnosis. There's a worldwide thyroid cancer epidemic. This is the overdiagnosis compared to expected instance. But here you see the United States, Italy, France, there is increase, Australia increase. I think this is the fee-for-service system. The more practice, the more revenue generation. But it's the England or Nordic countries or Japan, the proportion of the overdiagnosis is very small. And the breast cancer instance is different, pattern is different, but unimodal, it does not increase over time. But if we had the breast cancer mortality pattern in Korea is explained by the birth cohort effect rather than age or the period effect. And the medical care and the palliative care is a part of this one. And future challenges is third cancer control plan. We started this one in 2013, but we realized the number doesn't matter. It's overachieved. So we focus on cancer surveillance and also big data establishment and quality assurance for primary, secondary prevention, and more the treatment effect and supporting survivors and the research. And this is the kind of the supporting the cancer survivors. I'm still using the cancer survivor, but we think thyroid cancer is composing 21% in 2012, but more in nowadays because there's 1.2 million, but now 1.6 million most recent data. So we shouldn't call the survivor. They are supposed to have, I had the experience of the cancer, something like that. And this is the big data surveillance and also the control activities combining all the outcome research. And one of the interesting things is evaluate the effect of H. pylori eradication. The infection is number one attributing factor. In Korea, stomach cancer number one in instance. So we studied this one in general population, going the screening, H. pylori positive case randomized between the eradication or observation. And we started this written agreement with the IAC about 4 years ago. It's still undergoing. But preliminary data were actually published in the New England Journal of Medicine this year in March. The H. pylori therapy for the prevention of metachronous gastric cancer. So early gastric cancer patients, they had H. pylori eradication versus placebo control as preventive effect. There is 13% developed metachronous gastric cancer in placebo down to 5.2. As predictive value is very important. Odds ratio was 0.5. But if you see the persistent H. pylori infection case versus eradicated cases, then odds ratio, hazard ratio is much lower. So we are going to share this one. We opened the Graduate School of Public, the School of Cancer Science Policy 2003, and the first entrance examination and the commence ceremony 2 years later. And we have this one, the total 154 students entered, about 2/3 from Korea and more than 1/3 from outside of the Korea, and including Asia and Africa, as well as two from Canada, one from Australia. In closing, I think firm commitment of the government is the key factor for the successful National Cancer Control Program. Not only legal support, but also budgetary support. And the registry is very essential for the planning and evaluation. And the cancer screening program is effective and the integral part of a comprehensive health, the National Cancer Control Program. Cancer screening effect should be monitored and evaluated on a regular basis. Pitfalls over detection of indolent cancers, such as thyroid cancer, should be avoided. Thank you very much.